Well, thank you, Stephanie, and thank you to our panelists once again for that wonderful opening panel to really set the stage for a lot of our discussions that we're going to have the rest of today. So Stephanie's going to stay on stage to conduct a fireside chat, and I'll introduce our speaker that will be joining Stephanie. And so next up is I'll invite Marc Boutin to the dais. Marc is the Chief Executive Officer of the National Health Council. Marc joined the National Health Council in 2003 and was appointed the CEO in 2015. The National Health Council is the only organization that brings together all segments of the health community to provide a united voice for more than 130 million people with chronic diseases and disabilities and their family caregivers. Boutin has been a leading voice for greater patient involvement at every stage of the continuum, starting with the development of new drugs, to regulatory oversight of the healthcare delivery system, to shared decision-making at the point of care. Under Marc's leadership, the National Health Council has convened a broad range of stakeholders to create and effectively implement pragmatic strategies and public policy that address the diverse issues such as enhancing the patient experience and patient engagement, advancing the development of new therapies and treatments, and developing a better healthcare delivery system to meet the needs of people with chronic conditions and disabilities. I personally also serve on the National Health Council Board of Directors, and I can't tell you that there isn't a better advocate for those with chronic illnesses and disabilities than the National Health Council and Marc Boutin. So please help me welcome Marc Boutin. Thank you. Turn it over to you, Stephanie.
Well, it is really my extraordinary honor and pleasure to be up here with Marc to do this fireside chat. Picture, if you will, a fire. We are beside it. And it really is really exciting to be here and talk to Marc about the current state of healthcare and healthcare reform. You know, we were chatting last week and we thought, well, we don't want to prepare too much in advance because, you know, it's changing every day. And it continues to change every day. And we teed up a little bit on the last panel some of the recent developments with the American Health Care Act and it's sort of being pulled from the floor. But notwithstanding that, you know, the Affordable Care Act and autoimmune disease, it remains extraordinarily relevant. ARDA recently conducted a survey in connection with the recent election that asked autoimmune disease patients, you know, what matters to them in the election? What do they think lawmakers should know? Federal lawmakers, state lawmakers, the president. There is a press release in all of the packets as well as an executive summary of the findings. But by and large, you know, 94% of autoimmune disease patients who were surveyed agreed that, you know, federal autoimmune disease research is underfunded compared to other areas. They were concerned about healthcare policy in the future. They were concerned about potential repeal of things like pre-existing condition protections and things along those lines. And so we invite you to take a look at that survey and the types of things that matter critically to autoimmune patients. And as we do this session today, you know, we'll start with just a few questions to Marc, and then we'll open it up to all of you to ask questions based on his really terrific experience and his longtime advocacy and activism on behalf of chronic disease patients and autoimmune disease patients. So quite truly, we could fill a multi-volume treatise, and many people have, about healthcare reform and the Affordable Care Act, the implementation of the ACA and the implications of the repeal and replace effort from both a legislative and a regulatory perspective. So I want to start just by asking Marc, regarding the ACA repeal and replace effort, you know, the National Health Council has been very focused on the recent proposals introduced by Republican leadership in the House. Can you talk a bit about the policies that were reflected in that bill from a substantive matter, you know, and why you think the bill drew so much fire, not only from Democrats, but also from moderate as well as very conservative Republicans alike?
Sure. Thank you, Stephanie, and thank you, Steve, for the introduction. Very pleased to be here. One thing that we didn't include in the introduction that I want to share with this group is I became a patient advocate more than 25 years ago, and the reason I became a patient advocate was essentially everyone in my immediate family was diagnosed with one or more chronic conditions over a period of just a few months, and it ranged from heart disease, cancer, autoimmune, neurologic, and rare disease. Over a relatively short period of time, about 2 years later, most of those folks died as a result of not having treatments that were effective or having ineffective deployment of treatments that actually work. So I just want to commend you for all your efforts. What you do matters. I watched my mother suffer with a serious autoimmune disease that was part of taking her life relatively quickly. It's a tough issue. Don't give up on your advocacy work. It's critically important. To your question, the National Health Council has been involved in the Affordable Care Act and the repeal replacement for many, many years. And in fact, going back to the beginning of the Affordable Care Act, we worked with the patient advocacy community and were able to get more than 30 provisions into the Affordable Care Act that were ultimately implemented into law. The first year, we were the organization that championed the effort to not do one drug per class. 2 years ago, we got 12 modifications to the implementation, really trying to make things better for people with chronic conditions. Something we care about intensely at the council. When you look at repeal and replace, we tried to take a conciliatory approach with the Republicans, and we focused in on what we liked. And one of the things has already been mentioned, pre-existing conditions, exclusion. That was protected in the original bill. So were the out-of-pocket costs capped, the annual and lifetime caps were protected, and more than $100 billion was provided to help stabilize the market. So there clearly were things that we liked. But there were also clearly things we did not like. It dramatically reduced the subsidies. It eliminated the cost sharing subsidies altogether. And it eliminated much of the incentives for Medicaid. And as you all know, the Congressional Budget Office indicated that it would dramatically cut the number of people who had access to effective health care coverage. We took a conciliatory approach, said what we liked, said what we didn't like, and said we didn't support it. In the end, the bill was amended largely in response to negotiations between the White House and the Freedom Caucus to try to appease a large segment of the Republican bloc to vote in favor of it. Some of the compromises that were made would eliminate the essential health benefits and put that to the state level. Doesn't sound so bad, but our cost-sharing mechanisms are tied into the essential health benefits. The annual and lifetime caps were tied into the essential health benefits. Essentially, we lost each of the core principles we had fought for except pre-existing conditions. That was the only item that was left. And as a result, we took a very hard-line opposition to it. Obviously, it was unsuccessful. It was ironic that the far right did not support the bill, even with those changes. And if you think about it, had they supported it, they could have got the bill through the House. A lot of challenges bringing it into the Senate, but it was their best shot at actually repealing the vast majority of Obamacare. They started to also lose moderate Republicans, and so they lost on both ends and ultimately had a bad bill. And what I was quoted in the media saying, it was bad policy, it was bad for people, and it was especially bad for people with chronic conditions.
Yeah, thank you so much for those thoughts and that overview. And it really does underscore, how complex these issues are, how difficult it is to develop healthcare policy in a way that works and that works for key stakeholders. And, particularly with that effort to repeal the vast majority of the ACA, where we're turning now, and we started to talk about it a little bit on the last panel, is to states, but also to the agencies. Now that the ACA is chugging along, there is so much in the Affordable Care Act that gives discretion to the Department of Health and Human Services, to the Center for Medicare and Medicaid Services, including the essential health benefits implementation that you talked about. And you noted the efforts to to look at the prescription drug policy. You know, the statute says that the essential health benefits package has to include prescription drugs, but it's up to the agencies to define what that prescription drug coverage looks like. So maybe you can talk a little bit about what are some of the regulatory reform and regulatory implementation issues that are key on the council's mind as we move forward under the ACA framework?
So unfortunately, a lot of the key concerns we had with the proposed legislation remain top of mind as we work with the administration on what their next steps will be. I'm curious from the audience, how many of you, actually, let's start with this question. How many of you have coverage, healthcare coverage? Please raise your hand. I'm hoping all of you do. Good, I see all hands up. How many of you have it through an employer? So pretty reflective of the country as a whole. How many of you have it through the marketplaces? We have at least one. So one of the things that I think we forget about is that the ACA had a number of provisions that impacted almost all healthcare coverage, including a lot of the key protections. And we obviously want to ensure that they stay. Pre-existing condition has been top for people with chronic conditions. That's a key issue. Fortunately, we have an administration that is saying that's a key issue for them. So at this point, it seems to be off the table, but we have to keep our eye on that issue. Some of the issues that are particularly concerning is that essential health benefits were defined largely through regulation. We had the core categories defined in legislation, but the rest was designed by HHS. And the new secretary can change the definition of essential health benefits. Now, it largely impacts what is in the marketplace. The employer market will still have its benefits. We'll see it shift, but it doesn't necessarily follow as closely what HHS says. It tends to be more generous. But if the essential health benefits are changed, that means that issue, that coverage is outside of what will be covered in terms of cost. So let me give you an example. If you're going to have a child, and this was an issue in the bill, the essential health benefits could exclude maternal health and pregnancy. It could exclude certain conditions. It could change the variables with mental health parity. It could change coverage for drugs. It could go back to one drug per class. There's a lot of changes it could make. And if you're not in the essential health benefits, you're not protected by the annual or lifetime caps. You're not protected by the annual out-of-pocket cost. And you may not get the subsidies at the same level. So a lot of issues can shift that could have huge implications for your out-of-pocket cost and ultimately your access to the services you need. We've already seen this administration. I know this is important because I remember speaking with Virginia about this back during the days in ACA for this population. We've already seen this administration roll back the rules on who has to be in network. And we're seeing changes there that are making it easier to not have as many providers and specialists covered in your area. All of these create important access issues to the most vulnerable, high-cost patients who happen to have a chronic condition.
And it really is instrumental, these types of essential health benefits issues, the network rules that apply. A lot of these things were promulgated as rules under the prior administration, under the Obama administration. The current administration cannot change them without going through the sort of notice and comment process. There's a statute, the Administrative Procedure Act, that protects existing rules from being changed without going through notice and comment rulemaking. It's critically important for all the people in this room and all of our fellow advocates to monitor what's being proposed, weigh in on how it would affect you and affect your community. If they propose to roll back essential health benefits, we have to fight it. We have to offer our suggestions for how to make it better. And other rules, so many rules that were implemented under the prior administration, including the ACA's non-discrimination and healthcare protections, another rule issued by the prior administration. So very important issues. We'd also like to open it up to all of you, if any of you has a question that you'd like us to address. I have many more that I could ask for Marc too, but we'd love to hear what your questions are if you have them. Yeah.
Yeah, regarding the Administrative Procedures Act, I know the process. Did HHS, or did they actually have any, did they do anything with the comments that were submitted? I mean, there were thousands and thousands and thousands of comments that came in through that process. Did the bureaucracy address them? Did you feel that you got a response?
It's a great question, right? And so they are obligated to read them. They actually are. And they do tally them. They tally both how many they receive and they tally how many of them are unique. So they do. But you're right, at the end of the day, they choose within the scope of their discretion which policy they adopt. I do think it's important, though, because if we give up and if we stop commenting, then the tally gets skewed. Yeah.
Wondering the effectiveness of.
I do think that they get addressed, and I think that one thing that federal agency folks often say is they need the comments and they also need data and support. And I know that's a huge issue for the advocacy community is, getting our voice heard, but also supporting it and giving folks the tools that they need to adopt those types of policies. Marc, I'd be interested from your perspective. I know how instrumental the council has been, and you even mentioned, the provisions you got into the ACA, the changes you've been able to effectuate in the rulemaking process. What kinds of tips or advice or thoughts do you have for folks on how to do effective advocacy in this process?
Yeah, so I think your question is a really good one, and I will say in each administration that I have worked as an advocate in, our comments have been heard. They haven't always been accepted, including with the Obama administration. But I will say on the Affordable Care Act, each year we got significant changes through the rulemaking process. Now, this administration has not yet clarified what its strategy will be. And you heard a little bit of polar opposites from the president when the bill sort of went down in flames in the House. He said, on the one hand, the Obamacare is going to be crushed under its own weight. On the other hand, he recognizes that he needs to work with Democrats to develop a compromise. What that says to me is they're still trying to think through what their strategy will be at the regulatory level. They could do many things to cause the market to crash within the marketplace. And I think that's a critical thing to understand. If you step back for a second, the Republican, well, actually, even a step further, much of what's in the Affordable Care Act were provisions that were originally proposed by Republicans more than a decade before the Affordable Care Act was implemented. One of those provisions was a set of metrics to share money between plans to account for plans that had higher than anticipated costs because their patients had more chronic conditions or other acute care needs. All of that was predicated on negotiations with all stakeholders, including the insurance companies, with certain assumptions about who would be in the market. The assumptions were we'd have more healthy people in the market, so we got it wrong. And what happened was those risk-sharing mechanisms didn't adequately help the insurance companies. And that's part of the reason why you saw insurance companies pull out. And as they pulled out, you've seen premiums go up. Ironically, the Republicans, who had originally really crafted some of those provisions in a previous bill, decided this was the easiest way to destabilize the market. And so they opposed these funding mechanisms to redistribute the profits across insurance companies. And in doing so, they've created a challenge where it's, even what was in place is not being effectuated well. So you've got this challenge with the marketplace are to some extent intentionally being destabilized. And the insurance companies don't like it. It's also not good for us. Now, in the legislation they proposed, there was $100 billion to help stabilize the market. And the administration has said they would like to stabilize the market. If they go that route, there's opportunities for all stakeholders to have a successful pathway forward and to seek some compromises, and you'll see an opportunity to really impact the rulemaking. If they take the alternative tact and say, let's let it go down in flames, they're going to do what they can to undermine and destabilize the market. And they're going to do things that are going to challenge our access to services, to providers, and to medicines. And we just don't know which tack they're going to take. So it's hard to know at this point how much impact we can have, but I've never seen us have no impact. It's a really good question.
I have a question. Marc, you mentioned that this administration's already working to narrow the provider networks. Did they put that out to public comment?
They've, I'm trying to remember how they've moved that forward partially with some of the language in the executive orders, and I think you'll see an opportunity for some comment. But they've been very loose with how they've been doing that so far. So I'm curious, do you have more?
And there was a market stabilization rule that HHS proposed very shortly after Secretary Price was confirmed, and they did offer a comment period, a pretty short one.
Very short.
Very short. I think it was 30 days.
I think it was actually 30 days, but they did it on the calendar, so it became 20 business days. We did issue comments. It was a very truncated time period, and it's something that they were highly criticized for. It was quite unusual in my experience.
And it was, you know, it was done at a time when there was a lot of other things in the news, and so they issued it that way, but it did things like propose changes to the network rules, changes to the enrollment windows, so trying to shorten the enrollment windows. As stated, it was sort of, this will spur people to sign up if we give them a shorter opportunity to do so. But it's, you know, those types of changes, and I think the effective comment period was somewhere around 3 weeks based on how they proposed it and closed it.
And where does one go to kind of surveil what's going on and, you know, see what changes have been proposed in order to make comment?
Federal Register. So I'm actually, you can sign up if you want to be as delightfully nerdy as I am. You can actually sign up for Federal Register updates, including the public inspection desk. And I get emails 3 times a day from the Federal Register telling me what's been proposed. And anyone can do that. You can go to the federalregister.gov and sign up and get notifications. Your advocacy organizations can do that. You can have folks who monitor what's being proposed, what's about to come out, what the deadlines are. And you know, a lot of our coalitions and groups and listservs push information like that out, but it is available through those types of channels.
And we watch it very closely, and we'll put notice out to our members, including Otter, and we'll draft comment letters that people can tailor to their specific conditions. I will say in that specific instance, the way the rules on the timing were used, we actually got our draft letter out only about 4 or 5 days before the deadline. And we typically get it out much quicker than that. It just was a truncated time frame.
Thank you.
Do we have any other final questions? Well, I just want to thank Marc again for being here. I think we're about at our time, correct? So thank you so much for being here and joining us.
Thank you for all you guys do. Thank you.